movement that you see in a child or even in an adult are not nystagmus. You have to learn to differentiate the nystagmus from an imitator, which may be a nystagmoid movement or a saccadic disorder or a bobbing. So that's the first question one needs to answer. The another question is, if it is a nystagmus, whether it's a physiological nystagmus or a pathological nystagmus, because physiological nystagmus generally does not need any kind of investigation. Then if it is pathological, what is the cause? So with these three questions in mind, I'll take you through this presentation. We'll try and answer how we can approach a case of nystagmus. So all ocular oscillation, as I said, are not nystagmus. So is it a nystagmus? Or you have to see, because nystagmus is a regular, rhythmic, repetitive oscillation. So every single word is important. It's a regular. So the movement has to be regular in a particular direction. It has to be there has to be rhythm, and it has to be repetitive. Initiated by a slow eye movement with a fast corrective component. Right? So once we have so this is just to show that how this is a case of pendular nystagmus, where you can see that the eyes are moving in a particular rhythm and repeatedly moving. So coming to the characteristic of nystagmus, so nystagmus can be pendular or jerky, as we had seen in that case. Then it can be, it has to be classified according to the fast phase. So the direction is given according to the fast phase of the nystagmus. It can be horizontal, vertical, or torsional. Classified as small, moderate, and large depending on the amplitude, and again depending on the frequency, it can be classified as slow, medium, or fast. If the amount of movement, if the amplitude, frequency is same in both, is known as conjugated. If it's different, it is known as disconjugate nystagmus. So it has to be differentiated from the nystagmoid movement, which are not regular and are neither rhythmic. Oculopalatal myoclonus, opsoclonus, ocular bobbing, and Hyman-Bilchowski phenomena are example of such nystagmoid movements. So once you have established that this is a case of nystagmus, you have to know whether this is physiological or pathological. So there are physiological nystagmus in form of endpoint or end gaze nystagmus, vestibular nystagmus, optokinetic nystagmus, and voluntary. There are certain characteristics of these physical nystagmus. They are present only in extreme gazes, as in gaze. End gaze nystagmus, their trajectory is generally horizontal. They do not sustain for a long time and usually last for 3 to 4 beats. They are low amplitude in nature and generally are symmetric in amplitude and waveform, and no other neurological or any other systemic issues are seen. Vis-a-vis a pathological nystagmus, which does not meet all these criteria of physiological nystagmus, is classified as pathological nystagmus, and even though the exact mechanism of or the pathophysiology of these nystagmus is yet to be established, we know that's generally because of the three basic mechanisms. One could be because of the vision loss, which is secondary to the local ocular causes, or a vestibular dysfunction, or a neural integrator dysfunction, which may lead to motor nystagmus. So once you have established that this is a pathological nystagmus, you want to know, is it an acquired pathological nystagmus or a congenital pathological nystagmus, because an acquired pathological nystagmus needs extensive neuroimaging or neurological workup. So how do you differentiate between a congenital and an acquired case? So the congenital case is generally earlier in onset, less than 6 months, and an acquired usually later. Vision is generally reduced in a case of congenital nystagmus vis-a-vis an acquired nystagmus, where vision is generally well maintained unless there is some intracranial pathology that can along the visual pathway. The null zone is generally seen in congenital nystagmus, while you have no null zone in an acquired nystagmus. Oscillopsia is a common complaint in an acquired nystagmus. Latent component is absent in an acquired nystagmus, and there will be associated neurological signs and symptoms. So these are this is the list of pathological nystagmus. So more commonly what we see in children is congenital nystagmus, which is in form of infantile nystagmus syndrome or a fusional maldevelopmental syndrome. These are two most common kind of nystagmus what we usually see in children. So I'll be talking about each one of them. So coming to infantile nystagmus syndrome, it's a primary cause could be an ocular pathology, which may lead to the various degree of visual impairment, or a primary neurological cause that may or may not be associated with an ocular pathology, or it may be a simply idiopathic isolated INS. The features of INS include it's of generally binocular and conjugate in nature. It's uniplanar, no oscillopsia, abolishes in sleep, and improves with convergence and increased fixation effort, and distinct waveform is seen in slow ascending phase. It may or may not have eccentric null gaze. The null may be there in primary gaze or maybe in dextro or levo version. So this table similarly shows that how an INS can present. So it can present at an idiopathic nystagmus where there is some family history and it's, as I said, conjugate and horizontal. Then it can be associated with oculocutaneous albinism. It can be a PAX gene disorder or part of an achromatopsia. So this video just shows a case of nystagmus, infantile nystagmus syndrome, which is seen in a case of oculocutaneous syndrome. Now you can see that the patient has the null zone in the dextro version, and after beyond the null zone, the direction of the nystagmus changes. Similarly, another case of nystagmus, infantile nystagmus syndrome, where you have eccentric null zone, and the null zone changes once the and the direction changes once the target has gone beyond the null zone. So another variant of the nystagmus, infantile nystagmus syndrome is nystagmus blockage syndrome, where the amount of nystagmus is inversely proportionate to the amount of esotropia. So more a patient tries to fix, the intensity of the nystagmus comes down, but the amount of esotropia increases. The another variant could be congenital periodic alternating nystagmus. The next a kind of nystagmus is fusional maldevelopment syndrome, which has a manifest as well as latent component. It is also conjugate horizontally and horizontal nystagmus. The important characteristic is that it worsens on covering. So whenever one occludes the one eye, the nystagmus worsens and also changes its direction. So the direction of fast phase is always towards the fixin eye, and once the occlusion is changed to the other eye, there is change in direction of the nystagmus, fast phase of nystagmus. It's commonly associated with disease like infantile esotropia and TVT, also known as Chianza syndrome. Binocular vision is usually better in these cases than uniocular lesion and generally does not need any neuroimaging. So this is a classical case of fusional maldevelopment syndrome. You can see when the patient is trying to fix with the left eye, his direction or head posture has changed. So initially he has a right dominant. Now when you cover the left eye, the patient tries to fix with the right eye and his head posture changes again. The another type of nystagmus seen in children is spasmus nutans, which is a triad of nystagmus, torticollis and head bobbing. And the onset of spasmus nutans is infantile. This kind of nystagmus is pendular, horizontal, disconjugate, asymmetric, low amplitude and high frequency, and also increases on convergence vis-a-vis other types of nystagmus, which generally dampens on convergence. That is, it may have a self-resolution by age of 2 to 8 years. If not associated with any sensory deficit, may have strabismus, although rarely it may be associated with optic nerve or chiasmal gliomas. Gaze-evoked nystagmus is the most common type of acquired nystagmus, which is seen in cerebral lesion or drug toxicities. Is generally evoked on lateral gaze but is absent in primary position, and it beats in the direction of gaze. Vestibular nystagmus can be central or peripheral. Yeah, I just have few more slides, so I'll skip. So as I said, the approach includes detailed family history, detailed ocular examination, detailed examination of anterior and posterior segment to rule out any ocular pathologies that may cause nystagmus. OCT may be needed if there is no obvious fundus abnormalities. Subtle abnormalities can be picked up on OCT or maybe on electrophysiology, as was discussed earlier. Neuroimaging, so these are red flags when you want to do neuroimaging in a case of nystagmus. So late onset, oscillopsia, vertical with torsional component, disconjugate. So this how you work up a case of nystagmus. You can do nystagmography, or nowadays even video nystagmography is available. Most of the time, this non-surgical management is in the form of best refractive correction and adaptation with either prisms, or medical treatment can be done in cases of acquired brand. Surgical management is done only in cases where you have a definite head posture with an eccentric null position. You want to shift the head posture, so depending whether it's an INS or FMNS, you want to do the surgery accordingly. So in a case of INS, you want to do a shift of the null position by doing an Anderson procedure, which is the most common type of procedure that we do in our center. In a case of, this is also case of INS. In a case of fusional maldevelopment type of nystagmus, you want to do a bilateral medial rectus recession with posterior fixation, because you want to induce artificial divergence. So as I said, you have to have a very clear-cut thing about nystagmus, whether it's actually a nystagmus that's physiological, pathological, congenital, or acquired, and take up your approach accordingly.